Extract 1. Questions 1 to 12. You hear a gastroenterologist talking to a patient called Simon Mortlake. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Now, Mr. Mortlake, I think you've been referred by your GP. I've got your notes here, but perhaps you can tell me in your own words what seems to be the problem. What's brought you here today?
Sure. Well, it's not the first time I've been to this clinic. I was referred to one of your colleagues about 3 years ago. I had what I thought was a stomach ulcer, which had been troubling me for some time, and my GP suggested I came in for tests. And I had what he called an endoscopy. You know, where they put a tube down your throat and have a look at your insides. And as part of that, they also did a biopsy to make sure it wasn't something more serious.
That's right, and that was clear.
Yes, it was, fortunately. I actually had a condition called Helicobacter pylori, and I went on a course of tablets for that.
Right.
It was cleared up in no time, very straightforward. But the consultant did say that I needed to be alert for any further symptoms. You know, that there's a greater risk of cancer developing after you've had that, and that I should come straight back if I had any problems.
Oh, indeed. And have you had any other medical problems since then?
Well, a couple of years back I had a hernia operation. That was also very straightforward. I had that done just after I retired. I expect it was actually an occupational injury of some kind because quite a few of my colleagues have had similar problems.
Okay.
I was a police officer for most of my working life. Other than that, I keep relatively fit. I'm not taking any medication for anything. I've been well until just recently.
Okay. So what's happened to change that?
Well, I've started to suffer from indigestion, particularly after lunch or dinner. I get heartburn. You know, pain just here.
I see. And are there any other symptoms?
Well, I've also found myself running out of energy. I'm a keen gardener, and I'll be digging or whatever, and suddenly I feel a need to take a rest. I mean, that's not like me. I usually want to finish a job once I've started it, you know. But if I try to push myself too much, I start to get breathless. And that's a bit worrying, to be honest.
I see. And are you aware of your weight changing at all?
Not really. But what I have noticed is that I just don't seem to have such a good appetite anymore.
Right.
I mean, that's partly being retired, I'm sure, but I do keep pretty active. It's just that I don't fancy the sort of big meals I used to eat. I start to feel sick if I have too much.
And are there any other pains or physical symptoms?
Not really. I've been looking out for things like my stomach swelling up, because I know that might be a symptom of something. But to be honest, I can't say I've ever had that.
So what do you think might be the problem?
Well, the thing is, my uncle, that's my mum's brother, he had to have a gastrectomy. And I remember this is how it all started. I mean, the symptoms I've described, and, well, I think these things can run in families, can't they?
Well, they can.
Anyway, the real reason that I want to get checked out is because I've got a big trip coming up. The wife and I have booked tickets on a cruise to Antarctica. I mean, it's the trip of a lifetime. We're really excited about it, but I need to make sure I'm well.
Okay. Well, I understand your concern. So what
Extract 2. Questions 13 to 24. You hear a physician talking to a patient. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. Please be seated. What's your problem?
Well, I have been facing this problem with respect to tonsils for many years. I have throat pain.
Do you feel any difficulty in swallowing?
No, doctor, but I have got this habit of snoring loudly.
Do you get sleep apnea episodes?
No, doctor. Often, I am a mouth breather, especially at night times, doctor.
What's your age?
17. I had 3 bouts of tonsillitis this year. On an average, I get about 4 bouts of tonsillitis per year.
Okay. Have you had any illness, treatments, or surgeries earlier?
Yes, I had a cholecystectomy.
What medicines are you taking now?
Nothing, doctor.
Is there any family history of illness?
Well, my sister has ear infection. Rest of my family members have history of cancer, diabetes, heart disease, and hypertension.
Well, your physical examination results show your pulse is 80 and regular. Temperature is 98.4. Weight is 184 pounds. Your tongue, lip, floor of mouth are noted to be normal. Oropharynx does reveal very large tonsils measuring 3+ or 4+. They were exophytic. Mere examination of the larynx reveals some mild edema of the larynx. You have enlarged tonsils. You have developed chronic angiotonsillitis with angiotonsillar hypertrophy, upper respiratory tract infection with mild acute laryngitis. You have obesity issue. I would recommend that you go for angiotonsillectomy. The risk may include bleeding, infection, scarring, regrowth of the angiotonsillar tissue. There may be need for further surgery, persistent sore throat, voice changes, etc.
That is the end of Part A. Now, look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion between a doctor and nurse about different complications following heart attack.
Hello, doctor. What types of complications are expected following heart attack?
Well, there are 2 types of complications that can occur following a heart attack. The first problem occurs pretty much straight away, and the second complication occurs later on. Immediate complications following a heart attack are: arrhythmias is the immediate complications in which the heart beats irregularly, either too fast or too slowly. Cardiogenic shock is when the patient's blood pressure drops suddenly. Therefore, the heart cannot supply adequate blood for the body to function properly. Hypoxemia is the condition when the oxygen levels in the blood become too low. Pulmonary edema occurs when the fluid accumulates in and around the lungs. Deep vein thrombosis occurs when the deep veins of the legs and pelvis develop blood clots that either block or interrupt the flow of blood in the vein. Myocardial rupture occurs when the heart attack damages the wall of the heart. That has an increased risk of a heart wall rupture. Ventricular aneurysm is when a heart chamber called a ventricle forms a bulge. Question 26. You hear the discussion between 2 doctors about the impacts of acute kidney injury.
What are the impacts of acute kidney injury, doctor?
Acute kidney injury is a common and severe complication of surgery, especially cardiac surgery. Often, the complication is associated with higher rates of morbidity, mortality, and cardiovascular events, longer hospital length of stay, and higher cost. During stage 1, there will be an increase in serum creatinine of 1.5 to 1.9 times baseline, an absolute increase of at least 0.3 milligrams per deciliter, or urine output of less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. During stage 2 of acute kidney injury, there will be an increase in serum creatinine of 2.0 to 2.9 times baseline, or urine output less than 0.5 milliliters per kilogram per hour for 12 or more hours. During stage 3 of the condition, there will be an increase in serum creatinine of 3 times baseline, an absolute increase of at least 4 milligrams per deciliter, initiation of renal replacement therapy, urine output less than 0.3 milliliters per kilogram per hour for 24 hours or more, or anuria for 12 or more hours. Question 27. You hear a discussion between two doctors about acquired melanocytic nevi.
Hello, doctor. What are acquired melanocytic nevi?
Acquired melanocytic nevi are clumps of melanocytes that originate during childhood but manifest during 30 to 40 years of age. Junctional nevi form macules, with the skin markings becoming slightly more prominent. They are circular flat lesions with a uniform brown coloration. They have lentiginous cells, which are round or oval or spindle-shaped. Dermal nevi are raised pale brown or skin-colored lesions, and often hairy, having focal globules and fine vessels or pale areas. Pseudohorn cysts may be seen. The cells are epithelioid with amphiphilic cytoplasm, and the melanin is in granules. Compound nevi may be raised with a wart-like surface in certain cases, and are usually lighter brown than junctional nevi are. They have round or oval globules of pigment, and these may form cobblestone patterns. Question 28. You hear a discussion between a doctor and nurse about amblyopia.
Hello, doctor. Can you explain what is an amblyopia?
Well, amblyopia is the medical term for lazy eye that refers to a condition in children where the vision in one eye fails to develop adequately. This usually affects the ability of the child to see using the weaker eye. In strabismic amblyopia, a squint develops due to a mismatch between the muscles that support the position of the eyes. Therefore, the brain ignores the eye that is not straight and relies on the images generated by the stronger eye. In a condition called anisometropic amblyopia, the refractive error is greater in one eye than the other eye. Therefore, the brain ignores the more farsighted eye and relies instead on the eye that provides a clearer picture. However, the weaker eye remains straight. Therefore, the defect may go unnoticed by the parents or primary care doctor. In the condition called deprivation or occlusion amblyopia, one eye is deprived of vision due to the development of a blockage, such as a cataract. The ocular media becomes opaque, preventing visual information from reaching the brain. Question 29. You hear a discussion about miliaria.
Hello, doctor. What is miliaria?
Well, miliaria is the conditions associated with sweat retention in the skin, when the flow of sweat is obstructed. The sweat stays trapped within the skin instead of moving out from the sweat glands to the surface of the skin, developing various symptoms and signs including skin lesions. Miliaria crystallina, also called pseudomina, describes sweat duct obstruction in the uppermost epidermis, where the sweat is retained to form subcorneal vesicles. These clear, non-inflamed, fluid-filled blisters and papules rupture easily, and even light rubbing can cause them to break. Miliaria rubra, also called prickly heat, and refers to the retention of sweat that moves into the middle layers of the epidermis and the upper dermis, resulting in itching and redness around the sweat pores. Miliaria pustulosa occurs when the miliaria rubra develops as inflamed pustules. Miliaria profunda occurs when the sweat moves from the ducts into the dermis. Hard, flesh-colored, painful papules develop that are much larger and more deeply located than the papules seen in miliaria rubra. Question 30. You hear a lecture about different type of stents. We see today what is stent and what are the different types of stents. Stent is a splint that is placed inside a duct, blood vessel, or canal temporarily to aid healing or relieve an obstruction. Primarily, they are used to keep narrowed blood vessels open and patent, to allow sufficient blood flow or bodily fluid. Coronary stents are a tubular, mesh-like device that do not have any embedded medications in them. Drug-eluting stents are coated with medications to prevent inflammation and retinosis of the artery on a long-term basis. A urinary stent is used to hold open the ureter in cases where it is narrowed. Ureters are long tubes that carry urine from the kidneys to the bladder, where it is stored until it is emptied. Urethral and prostatic stent is used to open up the narrowing caused by an enlarged prostate pushing against the urethra, preventing the normal outflow of urine. Peripheral vascular stents are used to keep blood vessels outside the coronary arteries open. Stent grafts are tubular devices made up of a special fabric that is supported by a rigid metal stent. These are mainly used for vascular surgeries, such as to repair abdominal aortic aneurysm. Stents can also be used to keep the food pipe of the esophagus open in case of esophageal constriction, and biliary stents can be used to maintain adequate drainage of bile into the intestine.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor briefing his staff about guidelines for the early detection of cancer. You have 90 seconds to read questions 31 to 36. Guidelines for the early detection of cancer. I am going to explain to you the guidelines for screening different types of cancers. These screening tests are suggested to detect cancer before the patient develops any symptoms. Colon and rectal cancer and polyps. Starting regular screening at the age of 45 is suggested for people at average risk of colorectal cancer. The screening can be performed either with a sensitive test that examines for cancer signs in the stool of the person or with an exam to look at the colon and rectum. This can be done either with a sensitive test that looks for signs of cancer in a person's stool or with an exam that looks at the colon and rectum. If the person is maintaining a good health, he should continue with regular screening through to the age of 75. For people aged 76 to 85, they should confirm with the physician whether continuing with the screening is right or not. People above 85 should no longer get colorectal cancer screenings. If the person wishes to be screened with a test other than a colonoscopy, any abnormal result should be followed up with a colonoscopy. Cervical cancer. Cervical cancer screening should begin at age 21. However, women below 21 years should not be screened. Women between 21 to 29 should have a Pap screening done once in every 3 years. However, HPV screening should not be performed for this age group unless it is required after an abnormal Pap test result. Women between 30 to 65 should have a Pap test in addition to HPV test termed as co-testing done every 5 years. This is the most suggested approach. However, having a Pap test alone is also okay for this age group. Women above 65 who have had regular cervical cancer screening for the past 10 years with normal results should not be tested for cervical cancer. Once screening is discontinued, it should not be started again. Women with a history of severe cervical precancer should continue screening for at least 20 years after that diagnosis, even if testing goes past age 65. The women whose uterus and cervix have been removed, total hysterectomy, for reasons not related to cervical cancer and without any cervical cancer history or severe precancer should not be screened. Women vaccinated against HPV should still follow the screening recommendations for their age groups. Women with a history of HIV infection, organ transplant, DES exposure, etc. may require a different screening schedule for cervical cancer. Breast cancer. Women from 40 to 44 should have the choice to start annual breast cancer screening with mammograms. Women from 45 to 54 should get yearly mammograms. Women above 55 may get mammograms once in every 2 years. Screening should continue as long as a woman is in good health and is expected to live more than 10 years. Women should be well informed with the known benefits, potential harms, and limitations linked to breast cancer screening. Certain women with a genetic tendency, family history, or certain other factors should get screened with MRIs along with mammograms. Endometrial cancer. I would recommend that during menopause, every woman should be informed about the risks and symptoms of endometrial cancer. Certain women with a disease history may need to opt for a yearly endometrial biopsy. Lung cancer. I would recommend yearly lung cancer screening with a low-dose CT scan for certain people prone to lung cancer who meet the following criteria. Aged between 55 to 74 years and maintaining good health. And stopped smoking in the past 15 years. And having a minimum of 30 packs per year smoking history. Prostate cancer. I would recommend that men make an informed decision after consulting with a physician whether to be screened for prostate cancer. Research has not yet proven that the benefits of screening outweigh the harms of testing and treatment. Therefore, I believe that men should not be screened without understanding about the risk factors and benefits of screening and treatment. Starting from the age of 50, men should consult a physician about the risk factors and benefits of screening so that they can decide if screening is right for them or not. If they are African American or have a father or brother who had prostate cancer before the age of 65, one should consult a physician right from the age of 45. If one decides to be screened, he should get a prostate-specific antigen blood test with or without a rectal exam. How often he will be tested will depend on his prostate-specific antigen level.
Now look at Extract 2, questions 37 to 42. You hear the monologue of a physician giving a lecture on acanthamoeba infection. You have 90 seconds to read questions 37 to 42.
Hello, doctor. What is an acanthamoeba infection, and what are its types?
Acanthamoeba is a genus of opportunistic protozoan amoebic species widely found in the environment. Moreover, it is part of a broader family of free-living amoebae that can autonomously survive in the environment. However, it can also parasitize in humans and result in severe infections. Having discovered as a contaminant of yeast culture in 1930, it has become increasingly appreciated in the past few decades due to its potential to cause diseases in persons wearing contact lenses and immunocompromised persons, and also for its capability to act as a reservoir for various pathogens such as fungi, bacteria, and viruses. 3 major classifications of rare clinical syndromes can be caused by acanthamoeba. A fatal granulomatous amoebic encephalitis that involves the spinal cord and brain, acanthamoeba keratitis that involves the eye and disseminated infection that often manifests in many skin lesions, granulomatous amoebic encephalitis. Initially, the term granulomatous amoebic encephalitis was coined mainly to define the brain infection caused by acanthamoeba species. Nevertheless, the other free-living amoebae, especially Balamuthia mandrillaris and Sapina diploidea, can result in analogous clinical presentation. Most often, acanthamoeba affects the posterior structures of the brain in patients' diseases such as diabetes, renal failure, various malignancies, systemic lupus erythematosus, and human immunodeficiency virus. Other predisposing factors are organ transplantation, drug abuse, alcoholism, radiotherapy, or chemotherapy. It is often very cumbersome for the early clinical diagnosis of this condition, as symptoms mimic ischemic stroke or some other type of infectious encephalitis. In this condition, the disease usually manifests with headache, confusion, stiff neck, fever, lethargy, and focal neurologic deficits. As the infection becomes severe, the signs of raised intracranial pressure predominate, resulting in coma and mortality. Acanthamoeba keratitis represents a multifactorial process connected with the use of contact lenses. It can also occur in non-contact lens users, especially those with low levels of immunoglobulin A antibodies in their tear film or changes in the surface of the cornea. The process begins with the disintegration of the epithelial barrier and stromal invasion by acanthamoeba that induces a vigorous inflammatory response and subsequent stromal necrosis, with potential blinding. There is also a chance of bacterial superinfection that further complicates timely diagnosis. Usually, the symptoms are restricted to one eye and include swelling, pain, redness, tearing, light sensitivity or photophobia, abnormal contraction of the eyelid called blepharospasm, and blurred vision when the corneal lesion involves the visual axis. Disseminated infection and skin lesions. If acanthamoeba enters the skin through the nostrils or a wound, the organism can travel through the bloodstream, spread to other organs, and result in a disseminated infection. In such cases, the clinical process can be fulminant with swift progression to death. Infection with acanthamoeba species can also result in various skin lesions that usually start